Yes, thank you. Thank you for the invitation. My name is David Blok, and I'm working as an infectious disease modeler at Erasmus MC. Today I'm going to talk about the uses of modeling to predict the potential impact of leprosy diagnostics on transmission. So worldwide, more than 200 new cases are detected annually. And this map shows you the distribution of leprosy throughout the world, where Brazil, India, and Indonesia account for more than 80% of all the cases. So as the number of cases won't come down, this is an indication that transmission is still ongoing. And the current WHO strategy is to have early detection of cases and treatment with multi-drug therapy. However, as the numbers don't come down, it seems to be an insufficient strategy to actually break the transmission of leprosy. One of the reasons is that diagnosis of leprosy occurs based on clinical signs and symptoms, and sometimes along with slit skin smears and biopsies. This requires clinical expertise, and with diminishing numbers, this may also diminish, which result in longer detection delays and therefore more transmission within the population. Also, the long incubation period, which can be up to 20 years, actually hampers interruption of transmission, and also there's a lot of stigma around the disease, so people won't come out very freely and very soon to present themselves at a physician. So we all agree that early diagnosis is the way to interrupt transmission, and preferably in the subclinical stage. To do that, there's a need for a field-friendly diagnostic. This is not yet available for leprosy, but it is in development. Specifically, a diagnostic test that can identify infected individuals who will progress to clinical disease. As I said, the identification and validation of biomarkers are still investigated in several endemic areas. But with the development of such a diagnostic, questions may arise also in relation to leprosy transmission, such as what will diagnostic bring to leprosy transmission? What is the minimum test sensitivity required? And which testing strategy is most efficient in terms of benefits and cost when such a test comes into the market? So to answer these questions, we use mathematical modeling. So basically it's a quantitative description of epidemiological mechanisms and processes. We can measure burden and transmission and assess what-if scenarios. So it's basically the only way we have of predicting effectiveness of future programs. It has been applied in other entities as well in regard to diagnostics. A recent example is the OV16 antibody test, in which modeling has informed on critical thresholds of stopping MDA. So our leprosy model, also called SIMCOLEP, is an individual-based model. So what we try to do is to simplify the real-life situation. So we have individuals which are simulated, and these are structured in a population by households. Households are in particular important for leprosy because they are at the household context are at the highest risk of acquiring the infection. We also simulated transmission processes and the natural history of infection with M. leprae, and also the current leprosy control in place and the new intervention. In this case, the usage of a diagnostic tool to detect subclinical leprosy. So the natural history of infection as modeled in the study is as follows. We distinguish between possibacillary and multibacillary leprosy. So people upon infection progress to the asymptomatic stage and afterwards into the symptomatic stage. We only assume for PB that they might self-heal after some years. So basically the idea is that if we can find and detect this person at a very early stage, we prevent them transmitting the infection to other persons and also prevent them of progressing to severe disability. So in the study, we modeled the leprosy situation in northwest Bangladesh. We used the data from the SIMCOLEP study. This is a study focused on as a trial study on chemoprophylaxis. So in using our model, we try to assess the impact of using such a diagnostic tool on the transmission or the new case detection rate. And we applied several scenarios. First of all, we assessed the importance of test sensitivity. So we ranged the test sensitivity from 50 to 100%. And secondly, we assessed two different types of testing strategies. First of all, household contact testing. So in most high endemic countries, household contact examination is already in place. So what we actually add here is the use of a diagnostic test and a one-time population survey or testing. And these strategies are all compared to a no testing scenario. We also assess the impact in different levels of endemicity, so a high, medium, and low endemic level. So based on our findings, this is the impact on transmission. We have the new case detection rate on the y-axis, and the year since start of the interventions on the x-axis. We see that having a diagnostic would decrease the new case detection rate of leprosy, and by how much it decreases also depends on which type of testing strategy you would apply. The population survey potentially holds the greatest benefit. So in terms of time, we could see that reaching a certain threshold or level can be reduced by 9% up to 55% depending on the testing strategy. And the second thing I want to highlight based on this figure is that although we have modeled a time frame as long as 50 years, we can see that low numbers are not reached within a reasonable time frame. Secondly, we tested the minimum test sensitivity for a diagnostic test. In this picture shows the relative impact compared to the no testing scenario, which is the one line. And we see that with increasing test sensitivity, the impact increases. But we also see that at a test sensitivity as low as 50%, we can already see a substantial reduction in the new case detection rate. And if we focus on the second panel, where we have household contacts with a 3-year follow-up, you can see that the impact impact on transmission with a low test sensitivity can be increased by just repeating it in the same persons with a 3-year follow-up. So finally, we also compared all these testing strategies in different endemic areas in terms of the numbers of prevented new leprosy cases and the numbers needed to test. What we see in all areas is that population survey yields the highest number of prevented new leprosy cases. This is of course obvious. But if we look at the number needed to test, then household contact tracing is in this regard the most beneficial. And in terms of when we speak about limited resources, these are figures that can be helpful to make up your mind in which area you could in which area to apply which type of strategy. So to conclude my presentation, I want to say that diagnostics with a sensitivity as low as 50% could already result in a significant reduction of the new case detection rate, and that testing in the population survey is most favorable to achieve the short-term reduction of NCDR. And you see that zero transmission of leprosy might still be difficult to achieve in a reasonable time frame. I want to acknowledge all the people who were involved in this study. and also the founder of Novartis Foundation. Okay. Thank you for your attention.